Parkinson's. This is a slow, progressive neurologic movement disorder. The problem here is a deficiency in dopamine. So here's your pathophysiology. The problem is the deterioration of the substantia nigra. This is the portion of your brain that produces dopamine. Now, what is dopamine? Let's review. So we know about acetylcholine, yeah? So acetylcholine is the neurotransmitter for muscle contraction, for muscle movement. For us to be able to control those muscle contractions, that's where dopamine comes in. So acetylcholine is excitatory, dopamine inhibitory. Okay, so again, dopamine, long story short, dopamine allows you to control those muscle movements. So if there is enough acetylcholine but not enough dopamine, what is now the problem? There's a inability to control or refine motor movements. So that's why you'll see the manifestations will be mostly tremors, okay, and then uncoordinated muscle movements. Let's go to the signs and symptoms. The acronym of the 4 cardinal features of Parkinson's are tremor, rigidity, brady or akinesia, and postural instability. Tremor, the tremors here is resting tremor. Different from multiple sclerosis, because multiple sclerosis, the tremors occur on movement, meaning they have intention. There is intention tremors in multiple sclerosis. In Parkinson's, it is resting tremors. You'll see probably Michael J. Fox, when he appears in public, you notice him constantly moving, yeah? As opposed to, you remember Muhammad Ali when he was appearing publicly during his last years? He was still, okay? So Ali was not moving a lot, but you see him shaking a lot. Whereas Michael J. Fox figured out that if he keeps moving, he can keep the tremors under control, okay? So that's the tremor. Rigidity, there are different levels of rigidity here. There can be lead pipe or cogwheel. This refers to the level, the severity of the rigidity, meaning what's worse, lead pipe or cogwheel? Well, actually, they're the same, okay? So it's really rigid. I mean, imagine a lead pipe. Okay? If you're moving like that, that's pretty rigid, yeah? Whereas if you still have the jerky movements, okay, so this is uncontrollable shaking, okay? So there are different levels of the rigidity, the muscle rigidity. Brady means slow, and there can also be akinesia, which is no movement, okay? Now, most patients with Parkinson's have both, meaning they will have periods of bradykinesia, but they'll also have moments of akinesia. Most of these are related to the medications no longer taking effect, because what happens to the body's response to a medication, the longer you're taking them, because this is a chronic problem. So you'll have, let's say you're on Sinemet, which is the most common treatment for Parkinson's. You've been on it for 5 years. Is it going to be still working? What do we call that again? What have you developed? Tolerance. So once tolerance hits, the drug loses its effect, the patient goes into akinesia. So they develop freezing episodes. But most of the time, they'll have bradykinesia. And that's every day. They will have bradykinesia. So what they want to avoid is the freezing episode, because that means, could they choke? if they have a freezing episode? Could they fall? All right. We'll do management shortly, but most of these is usually because it's a dopamine problem. There's really no problem with the muscle. It's the neurotransmitter problem. So most commonly, yes, I'm not saying there's no PTOT. There is. However, it's more on the medication management. Postural instability, this is described as a propulsive gait, meaning the patient will be, if you read this, it says the head bent forward and walks in a propulsive gait. So when you see them walk, it's as if they're about to fall flat on their face, but they won't. They just walk like this. Unlike you, wherein you walk upright, these patients will have a forward facing gait, and they have shuffling gait. So they cannot lift their feet like this when they walk. Instead, they will be like this. And then propulsive again. So propulsive or shuffling gait right here. So that's the pattern of their walking. Okay. And this is very almost exclusively found in Parkinson's disease patients. Okay, so they have this forward propulsion kind of gait. There are other manifestations, but those cardinal features again are the trap. So we got tremors, rigidity, akinesia or bradykinesia, and the postural instability. So there are other autonomic problems because dopamine has different functions. Dopamine doesn't just control muscle movement, but they have purpose in blood pressure control, meaning so if you're low on it, you will have hypotension. You have orthostatic hypotension. So you have the sweating, the drooling, paroxysmal flushing. So these are all consequences of low dopamine levels. Swallowing is a major problem, just like in stroke. Patients with Parkinson's are high risk for choking and aspiration. Eventually, the longer they have Parkinson's, they will eventually develop dementia. There can also be even psychosis. So it's not rare for them to complain of hallucinations, both visual and auditory, and that eventually leads to psychosis, meaning they'll see and hear things, and that makes them psychotic. So you can also already foresee the treatment. It's not just about increasing dopamine levels, but also treating dementia, treating psychosis, and to diagnose, it's usually a CAT scan or MRI, PET scan to see if there are other possible causes, okay, besides Parkinson's, because this can be misdiagnosed, especially early on, meaning the patient doesn't have the trap yet. So we may not arrive at Parkinson's. In fact, they may be diagnosed with multiple sclerosis initially, and then later just diagnosed with Parkinson's. Management, it's most likely just medications. But of course, it's always collaborative. We approach it multimodal approach. But mainstay treatment is medications. Now, what medications are used? So these are the goal of therapy. So anti-Parkinson medications will be reducing the symptoms, which is the tremors, okay, and the rigidity. Early on, almost all patients will be started on levodopa carbidopa, brand name Cinemet. Probably seen this in your patient's Mars. Okay. It's never given alone because remember the blood-brain barrier? Okay. So because of the blood-brain barrier, when we give levodopa alone, levodopa is dopamine. When we give it alone, most of it is destroyed as it crosses the blood-brain barrier. So very little makes it to the brain. So to increase the likelihood that more dopamine crosses, it's given with carbidopa. So it's always combination, levodopa, carbidopa, which is cinnamon. But benefits begin to wane eventually. So within 5 to 10 years, the patients now have a tolerance to the drug. So can we continue with Cinemet? No, it's time to change now. So once they have these manifestations now, so it's time to switch to another drug. We call this, which is common with Cinemet, on-off syndrome. Of course, we're happy with the on syndrome. What we don't want is the off, because when we have off, then they have these dyskinesias. What is dyskinesia again? You discussed this in psych, mental health. You know, this lip smacking movements thing. I get right? Very like that. No, this jerky movement. Usually like that, uncontrollable facial and arm movements. Yeah, you've seen videos like that, right? It should have been discussed in mental health. This is common in people taking psych medications. Okay, so the longer you're on psych meds, let's say you're on those medications for bipolar disorder or uh, schizophrenia, yeah, so those drugs, you will develop dyskinesia. Okay, so it's also seen here in patients taking Cinemet for a long time. No, Tourette's is different. So here, head bobbing, chewing, smacking movements, these are very common. And these can be embarrassing because again, the patient doesn't have control over these. So you're in public and you have these movements and you have no control over them. They just appear, okay, when you least expect it. So how to manage on off? Changing the drug or the dose, okay, or different regimen altogether. Okay, so we'll switch from Cinemet. So again, let's say it's been 5 years, 10 years, you're on Cinemet, then you're having these symptoms. Doctor, your neurologist will say, okay, it's time to switch. The other medications will be later in the chapter. Surgery, will skip the surgical management. You think Muhammad Ali, Michael J. Fox, with all their money, can't afford surgery? Of course they can. But why do you think they still had the disease? Do these really work? Okay, so let's skip that. Okay, doesn't matter. So here's our medications. So the more successful treatments for managing symptoms. Now, don't get me wrong, there's no cure for Parkinson's. Okay, so all of these are symptom management only. So we've got anticholinergics. Just like with any other anticholinergic, what are problems with anticholinergic agents? Dry mouth, what else? Tachycardia, constipation, yeah, edema, urinary retention. Between these two, the benztropine is, which is Cogentin. Benztropine is more commonly prescribed. Antiviral, amantadine. Amantadine can also be used for bipolar disorder, and some autism patients can also benefit from amantadine. Amantadine is it's actually a, oh yeah, it's already mentioned here, right? It's an antiviral agent. And these are the purposes for prescribing it. And these are your side effects or adverse effects. Bromocriptine, dopamine agonist. So of course, this one will increase dopamine levels. Ropinirole is simply for movement. You've heard this drug before in restless leg syndrome. So this is also helpful in restless legs. Then MAOIs, COMT inhibitors, either entacapone or tolcapone. These usually are not given alone. This is usually given together with Sinemet. The good thing, this is now, well, it has been for a while. This is covered by Medicare. Okay, so entacapone together with Sinemet will improve symptoms, okay, together. And those are your most common treatments. Okay, so again, benzaprine, amantadine, bromocriptine, ropinirole. MLI is not really that common, but entacapone or tolcapone, yes. The rest of the management here are related to symptomatic management. So the neurotransplant, any surgical option we skip. Let's go to your collaborative. So PTOT, most patients with, I know you see them in nursing homes and hospitals, but most people with Parkinson's actually live independently. Some of them even live alone, especially now that we have telehealth, telemedicine, by phone or video. Okay, and if you want, there's a program, there's jobs for that too. Let's say you're a mom, don't want to leave home, you have small kids. This is an option for you. So you go into telehealth, and these are your clients. Okay, patients living independently with Parkinson's, multiple sclerosis, etc. So your job here is to check on them 3 to 5 times a week. Make sure they're keeping up with their medications. Check what are their symptoms, how are they doing, when is their appointments, okay? Do they have enough medications? And then, of course, part of the planning will be for contingencies. Let's say you expect a storm coming, for instance. Now, it may not be as big of a deal here, but when you're talking patients out in the Midwest, for instance, or out in Montana. So it's a bigger problem there with logistics. Yeah, I mean, drug delivery is not as easy it is here, where you have hundreds of UPS trucks, for instance. How often do you think the deliveries will be out? Yeah, North Dakota, somewhere. Okay, so if your patients are there, then you need more advanced planning. So you work with PTOT, with mobility. And please read the things in detail, because I'll copy and paste these options on the select all apply, right? Meaning here on the details here. So I'll copy and paste them on the select all apply questions. So we encourage self-care, of course. And part of this would be mostly safety, not only for swallowing, but fall precautions, maintaining bowel elimination, nutrition. Most of them lose weight because of the swallowing difficulty, chewing and swallowing difficulty, for that matter. How often do we monitor weight? Weekly. Because this is a chronic patient. If it's nutrition that you're doing the weight monitoring for, it's weekly. But what if it's for fluid status? Is it weekly or it's daily? If needed, the patient will require a PEG tube. Okay? If they cannot meet their calorie requirements by mouth, then we will discuss PEG tubes. For enhancing swallowing, this is the speech language pathologist, so I'll skip through that. Assistive devices, no different from patients after a stroke. So same adaptive devices, the forks, spoons, knives, cups, plates. Communication, again, on the speech pathologist side. And coping, especially if you have a younger patient. If this patient was the breadwinner, okay, so assist the family maybe refer them to, we do have several support groups in every community. So explain to them the benefit of attending support groups. It's always better if you feel you're not alone, yeah, that you have people who are going through the same things as you and your family does. And same thing again for complications, not just for aspiration, which will lead to pneumonia, but the pressure injuries, falls. The falls here can also be from the orthostatic hypotension. Now, it's not just Parkinson's that causes it. The drugs also can lead to orthostatic hypotension as well. And explain later on in the disease, once the patient develops hallucinations, visual, auditory, or tactile, and then tell the family to expect, some psychotic behavior, then tell them when to call 911. That's about it. Any questions on Parkinson's? Okay, let's go straight to the next one. I just discussed that. Next is Huntington's disease. This is short. Huntington's disease is genetic, hereditary, passed on from generation to generation. So just like any other hereditary condition, a sickle cell disease, for instance. So same thing. This one is actually worse than Parkinson's. Parkinson's can live relatively normal lives with medication and proper support, collaborative support. Huntington's disease is always fatal. Once the patient is diagnosed, they can live for probably 3-5 years, and that's it. The sad thing about Huntington's is, yes, it's present at birth, but you don't manifest the signs and symptoms until you're in your 30s. So let's say, Solev, you are born with Huntington's disease. You live normal life up to your 30s. So what are you doing in your late 20s, early 30s? You're living normally, right? You're going to nursing school, you have your career, maybe meet someone, and then have kids. And then suddenly, you're 36, 37, you manifest the disorder. Again, it's genetic. Okay? Here are your manifestations. The Huntington's disease, the main feature is Huntington's chorea. Chorea means dance. No, from the root word chorea, which is choreography, okay? Dance. This dance, though, is nothing impressive, okay? So the dance here is totally involuntary. Involuntary muscle activity. Okay? The patient loses control over voluntary movements. So here you have rapid, jerky, involuntary, purposeless movements. And the patient eventually, after a year or two, develops cognitive impairment, meaning they develop dementia. And that's it from there. Because you cannot control the movement, so what will happen? This patient gets up. They'll fall, hit something, and then that's it. They're admitted for something. And can they eat? And imagine, this is nonstop. Okay, they cannot stop movement. Can they have a time to sit still and eat a meal? And how much energy, how many calories are they burning up with this chorea? A lot. So not enough intake, but they are burning up so much energy, so many calories. So they lose weight, and you can just imagine what goes on from there. Okay, so the patient early on, the cognitive function is intact, but then eventually they lose it. So let's say it happens to Soler. So his kids, what will happen to his kids? Hey, what's happening to daddy? Okay. Now he's 38, 39. He's in a facility now because the family, it's impossible to care for him at home safely. Okay. Unless you all want to just stop doing your work or school, this patient requires 24/7 care. Okay, so most of them will have to be institutionalized. Okay, and then from there, you just imagine what will happen. So this organized speech and gait, and then eventually the patient will be bedbound and lose bowel and bladder control, and then that's it. So it's not something you want to have or pass on, correct? So therefore, what's always included when you have in the management, if you have Huntington's chorea or Huntington's disease? Genetic counseling. Do you really want to have kids? The problem is, what if you didn't know your parents' history? Hey, you didn't know. But once you have it though, once you know you have the gene or you have the manifestations, is it really wise to have biologic children? No. Do you really want your children to have this? Again, onset is between 35 and 45 years of age. So patients succumb to complications in 10 to 20 years after the onset of symptoms. So they don't grow old, do they? So you'll never see a 60-year-old patient with Huntington's. Okay, they die early. But I mean, where are you during those last 10? Yeah. Oh yeah, sickle cell, because there's better treatment now. But I mean, not all though. Again, I've never seen lately. I haven't really seen a 50-year-old sickle cell patient. Usually young people you see in hospital, 20s, 30s. I've never seen one. In my case, I've seen more females in my case. Anyway, so let's finish this. We have no questions on the diagnostic because we don't have a role there. For management, it's all medications just to control the movement. Okay, just to slow them, control the movement enough so that they can sit still, eat, uh, chew and swallow. Right, that's the best we could do. So for treatment, options are levodopa, so same as Parkinson's, benzodiazepines to, we have no choice. We have to semi-sedate them to keep them calm. That's about it. It's all about safety. So you have chart 65-4, maintaining safety. So fall precautions, injury, because they'll hit stuff, okay, when they walk. Try looking at YouTube and searching Huntington's disease, you'll see sad videos, okay, of people suffering and what the movement is. The dance, by the way, is never the same. It's not like the same choreography where, like this. It's the same. No, it's never the same. The dance will always be different. Each time, it's never the same. Any questions? Okay, last one before a break will be ALS. Then we'll proceed with multiple sclerosis when we come back. This one's even shorter. So what is ALS? We have no idea what causes it. We know it affects the motor neurons in the specifically anterior horns of the spinal cord and the lower brainstem. Other name is Lou Gehrig's disease. Onset between 40 to 60 years of age, so you could be living normally. And then later, when you hit 40 and 60, you develop the disorder. It's pretty quick after, if it's really ALS, the prognosis is poor. You're dead by the time you hit 3 or 5 years after the diagnosis. The only treatment is to slow it down. There's only one known drug to to slow it down. Basically, it's just going to buy you time. You're still going to die, but it buys you a few months, maybe a year, before you're on a mechanical ventilator. Because again, you're between 40 and 60 when this hits. So you're a parent, right? Around this time, you have a career, you're a parent, then this thing hits you, now you're bedbound. So these are the manifestations. So it will eventually lead to paralysis. So early on, fatigue, muscle weakness, cramps, twitching, lack of coordination, and then this goes downhill from here. Starts with the arms, trunks, legs. So your mobility will be, maybe you'll be on crutches first, and then leg braces, eventually a walker, and then a wheelchair, and then you're bedbound, and then eventually you're on a vent. We don't know the cause, but there are risk factors. It's not easy to diagnose. There was one special I saw with Sanjay Gupta on CNN. He was interviewing this doctor who claims to have cured 10 patients with ALS. The problem with his story was there were no second opinions, meaning other doctors were skeptical about the diagnosis of his patients to begin with. They don't think they were ALS. But he claims they were ALS patients, but then, that they were cured, and then it's just puzzling. Why would these patients be cured? The rest, no. So maybe they weren't really ALS patients. So to date, no cure exists, mainly supportive. So this is between these two drugs, this one is more common, Riluzole. I think the brand name is Rilutech. The drug is hepatotoxic, so you need monthly liver enzyme monitoring. This is very harmful to the liver. Again, it only slows down the disease progression. Other treatment is simply symptomatic. For the back spasms, the painful muscle spasms, you give them baclofen. Will these patients eventually have depression? Yeah, I would be depressed if I have this anxiety. So they'll be given benzodiazepines for that, antidepressants. That's about it. Okay. Again, the end result here is the patients will be on a vent. Those who end up on the vent obviously did not have a very well thought out plan, meaning I don't know what to say. I mean, they're educated on the prognosis, yeah. So of course you're bound to plan ahead, yeah, about advanced directives. It's not going to change the outcome. You will die, but no, some patients choose, okay, yeah, do everything. They'll have a trach, bedbound for however long. Sometimes it may not be the patient, maybe the family and the children, okay, who refuse to, yeah. So I don't know. Each story is different. So just like any other debilitating condition like this, so once you're on a vent, then you are gonna have a trach, yeah? and then you'll have a peg tube, and then of course you most likely will have pressure injuries, Foley catheter, and repeated COTI and pneumonia episodes because of these. So one of those, if you don't die from ALS, you probably die from one or more of the complications, like sepsis, for instance, from either an infected, UTI, sepsis from UTI, sepsis from pneumonia, or sepsis from an infected pressure injury. Story is the same. Any questions? Okay, come back at 3 o'clock.